Thank you very much for this invitation for speaking on managing of thrombus in the cath lab. It's a vast topic. I will try to focus on only few aspects, and that too in the form of snippets on this managing of thrombus in the cath lab. Now, it is important that you take care of the thrombus by recognizing it and handling it very carefully, because there could be distal embolization during PCI, giving rise to various complications, most common being no reflow or slow flow, acute occlusion of the vessel during or at the end of the procedure, peri-procedural myocardial infarction. These are the complications of a thrombus in the PCI. This also increases the cost and later on can give rise to early and late stent thrombosis and a significant risk of recurrence of MI or death within the first 6 months. The most important aspect is at first to recognize and diagnose that there is a thrombus. The detection of thrombus is very poorly sensitive as far as coronary angiography is concerned. It may be seen as a space-occupying lesion within the coronary artery or a staining of the dye in a particular area where the dye remains for quite some time. It may have an irregular lesion with irregular contours, with filling defects in these contours, suggesting that there may be a thrombus in the coronary artery. Or in a total occlusion, there may be a smooth convex meniscus at the site of the occlusion, giving rise to a doubt that there could be a thrombus in the coronary artery. In order to detect the thrombus, we need imaging as a tool along with coronary angiography, which in the form of OCT or IVUS. This on the OCT is seen as a mass protruding into the vessel lumen, which could be a red thrombus or a white thrombus, depending on the age of the thrombus. A red thrombus, there will be high backscattering and signal free behind the thrombus. In case of white thrombus, which is rich in platelets, there will be low backscattering behind the thrombus. It can be also detected on the IVUS as a filling defect, or there could be a variegated appearance in the grayscale or a very hypoechoic area within the coronary artery lumen at the site of the lesion, giving a suggestion that there is a thrombus in the coronary artery. Now, when we are facing with the thrombus, the problems of high thrombus burden is that it can get dislodged during the procedure, as the friable elements of the thrombus can give rise to no reflow or slow flow or side branch occlusion, or even aspiration of the thrombus backwards and then embolizing into the vessel which is proximal to the target vessel. This increases the peri-procedural MI multiple times in the given patient, and in the case of MI, after the procedure, even the ST segment resolution may be present, may be impaired, and the STs may remain elevated for a significant length of time. It could also give rise to procedure-related death. That's why we have to be very careful. One of the aspects is thrombus aspiration. Now, it has been seen that thrombus aspiration increases the procedural success with a lower in-hospital MACE. However, the long-term survival with or without thrombus aspiration with only a PCI is in no way different, and it doesn't add any much advantage to this. But the primary procedural success is much better with thrombus or with thromboaspiration. This can, however, during the procedure of thrombus aspiration, the thrombus can get embolized distally, especially if it is a large organized thrombus. And that's why we have to be very careful while using the thrombosuction device. For example, here I have a lady with changes in the anterior lead, and the patient has received streptokinase and has come to me 3 days after that, and you can see a thrombus in the LAD. On the OCT, you see a significant amount of thrombus in the proximal, in the LAD over there, and which is protruding in the lumen of the LED, and it is occupying a significant part of the lumen of the LED. We did thrombus aspiration, and subsequently we also used a balloon. However, you can see there is a residual lesion still over there. So what do we do now? We repeated the OCT, and on the OCT we see there is a residual thrombus there. So the thrombus, which is 3 days old, is not completely cleared, because even after thromboaspiration. We kept this patient on heparin for 1 week, followed by oral anticoagulation, and after 3 months we repeated the CT angio, and we see there is no residual thrombus and the vessel is clean. However, we should, when we do an aspiration and we defer the stenting, there is a problem for difference. It's a double-edged sword. If we defer the stenting in these patients after thromboaspiration, then we avoid slow flow or no reflow. However, in the interim period, there is a chance of recurrent ischemia in this patient. So these patients who are to be subjected to deferred stenting should be selected properly and kept under observation in the hospital and treated accordingly. We are more worried about no reflow or slow flow in patients with thrombus in the coronary artery. For example, we see here this gentleman. After the stenting in a right coronary artery, the flow is very slow. This is less than a TIMI3 flow. There is no TIMI3 blush at all. So in this patient, because of the slow flow, we have given intracoronary vasodilator, and we see that the flow is much better now. So no reflow or slow flow is considered when the TIMI flow grade is less than 3 and the myocardial blush grade is less than 3. And this occurs in more than 20% of patients undergoing primary PCI. This occurs due to distal embolization of the thrombus or the debris, intravascular plugging from the platelets and microthrombi in the small vessels, giving rise to release of cytokines, which can give rise to microvascular spasm and giving rise to ischemia and reperfusion injury. Now, who are the patients who are more prone to no reflow or slow flow? These are patients who have got a high grade of thrombus, which is at least 12 to 24 hours or more in age, in duration. The lesion in this particular patients are usually long lesions. Of course, there may be shorter lesion, discrete lesion, and there is a combination of the length of lesion along with the severity of the thrombus. Those patients who have got a slow TIMI flow, they have got a higher chances of slow flow or no reflow. Or those patients who have got hemodynamic compromise, they may have a higher chance of slow flow or no reflow. In order to avoid this, least amount of intervention should be done inside the coronary, favoring a primary stenting and avoiding any high pressure post dilatation, so that the spasm, microvascular and the distal vascular embolization is prevented. In patients with SVG grafts where we are doing a PCI, embolic protection devices are important. However, in primary PCI in the native coronary artery, embolic protection device has no role. So overall, if you have a short door to balloon time, and if we are doing thrombus aspiration, we can prevent no slow flow or no reflow. However, thrombus aspiration is a double-edged sword. It can by itself also give rise to slow flow or no reflow. And this slow flow or no reflow can be treated by intracoronary vasodilators. My favorite is nitroprusside given intracoronary or intracoronary injection of nitroglycerin. However, besides that, we can give adenosine or verapamil or diltiazem or even adrenaline, depending on patient to patient. In patients who have got thrombus inside the coronary artery during the procedure and after the procedure, there is a high chance of stent thrombosis. For example, in this particular patient, where a primary angioplasty was attempted on the circumflex and it is totally occluded. And in this particular patient, there was a thrombus inside the coronary artery after stenting also. That means in this particular patient, we cannot see any edge dissection. There is a thrombus inside the coronary artery. So this patient has developed this thrombus because this patient's anticoagulation was inadequately controlled. Instead of taking care of the anticoagulation, the gentleman preferred to put one more stent here. However, it has not helped in this particular patient. 3 weeks down the line, the patient presented to us, and we see that the thrombus is well organized, the vessel is very thin, and this vessel is still diseased, giving rise to ischemia in this particular territory. So, when we are facing with stent thrombosis, what are the predisposing factors of stent thrombosis? Most important is inadequate anticoagulation and inadequate antiplatelet therapy prior to starting the procedure. Also, there are anatomic or pathological factors, like if there is a bifurcation lesion, a type C lesion, a severely calcified lesion, that means a complex lesion, then the chances of stent thrombosis are higher. If the TIMI flow grade at the end of the procedure is not satisfactory, then like this previous patient, then in these patients, the chances of stent thrombosis is high. It also depends on during the angioplasty and stenting. If the stent is underexpanded or malapposed, then the chances of stent thrombosis is very high. And that is why during these procedures, we need to have imaging to be done to see that the stent is appropriately apposed and appropriately expanded. Most important thing is that whenever we are suspecting stent thrombus, you have to do an IVUS or the OCT and not just an angiographic study. And if there is a fracture, or if there is, especially if there is under expansion and malapposition, we have to oppose the stent appropriately and never directly go for repeat stenting, especially in under expansion. Repeat stenting can be performed if the stent thrombosis is due to edge dissection, either proximal edge or distal edge. And if it is because of under expansion or malapposition, repeat stenting is of no use. It will complicate the matter further, as we have seen in the index case, which I have shown previously. Coronary aneurysms are very notorious for thrombosis. They can have a thrombus, as for example, this gentleman has presented to me with an anterior wall MI. We do an angiography, total occlusion of the proximal LAD. We did a balloon dilatation with a graded higher balloons, but you see there is a thrombus there. There is a trickle of flow, not even TIMI grade 1, and there is a large thrombus sitting over there. We did thrombus aspiration for this patient, and in spite of thrombus aspiration, the thrombus is still present in the coronary artery. Then we gave this patient heparin for 5 days, and we repeated the angiography, and the repeat angiography shows there is at least a TIMI 2 to 3 flow, but the thrombus is still pending, still there in the coronary artery. Now, it is dangerous to do a stenting or further balloon dilatation in this particular patient. So we continued, they switched over from heparin to oral anticoagulation, and we repeated the angiography after 3 months. And after 3 months, there is no residual thrombus at all in the coronary artery. There is no residual stenosis also. So when you are taking a patient for PCI and there is an aneurysm, there is a very high chance of procedure failure and of no reflow and distal embolization in this patient. So patients with aneurysms have to be treated very delicately and as much conservative management as possible. So to conclude, this is a large topic, thrombus in the coronary artery, but I have given only few snippets because of the time limitations. And a thrombus in the coronary artery should be managed with due precaution, minimum intracoronary interventions. Thrombus aspiration is a double-edged sword. By itself, it can give rise to distal embolization. At the same time, we can aspirate and reduce the thrombus. So it has to be used with a lot of precaution and should not be used in old thrombi. And if it is only a fresh thrombus, we should use a thrombus aspiration. Slow flow and no reflow are preventable and treatable complications of patients who have thrombi in the coronary artery during the PCI. and they should be treated very carefully, and intracoronary vasodilator should be appropriately used. Stent thrombosis is largely preventable, especially if we can do imaging during and at least at the end of the stenting, so that we can detect if the stent is appropriately placed, appropriately expanded. There is no edge dissection, either the proximal or distal, so we can prevent stent thrombosis as much as possible. And a combination of pharmacotherapy along with invasive therapy is the best combination for treatment of PCI, treatment of coronary arteries lesions with thrombus to prevent any further complications. Thank you very much.